the percentage of inhaled oxygen, then 100% of the air going into our lungs is oxygen, and we displace nitrogen. So we call that nitrogen washout, and we can measure the residual volume by how long, if we extrapolate that volume by how long it takes to regulate or equalize the amount of the time that it takes to breathe in 100% oxygen and release all the nitrogen. That's nitrogen washout. The other way is helium dilution. So sometimes PFT labs will have a patient breathe in helium, and they're looking for a steady state of helium as we breathe in and out with tidal volume. The helium will go in, and you'll get a steady state of helium, and we extrapolate what the residual volume is by how long it takes to get the helium to a steady state. So there are 3 ways to measure residual volume: body plethysmography, nitrogen washout, and helium dilution.
So what does it mean when it's referring to closed circuit and open circuit?
So you're breathing in this box, and you're breathing through a circuit, you're breathing through a tube that goes to a machine that's measuring the helium or the nitrogen, goes to the patient, and from the patient it goes out. So you've got a circuit of air going in and out, and it analyzes it as it goes around this circuit. Sometimes you'll open the circuit, and sometimes you'll close the circuit depending on what technique you're using, open circuit or closed circuit. I would just remember those 3 ways to determine residual volume. Now, residual volume is stuck in your chest, and we don't have a way to measure it unless we do it with body plethysmography, helium dilution, or nitrogen washout.
Do you perform these tests pretty often?
Yeah. Everyone that goes for a full PFT, every lab will use a particular test. Some of them use body boxes, although not very often. I don't see body boxes very often. Do you see body boxes very often? Most labs have one.
Yeah, actually, wherever I work that's had a PFT lab has had a body box.
It does have a body box. So they're there, and they do use them, but it's easier to do helium dilution or nitrogen washout. Give them 100% oxygen, give them a little bit of helium, and you watch for a steady state. It's an easier test, and it's an extrapolation. So what do you think you're trying to determine? If you're measuring the residual volume, what disease characterization are you trying to make? What are you trying to determine? Yes, is it obstructive lung disease or not? Exactly. You're trying to see if it's larger than normal. If it's normal, we can't really make a determination. If it's larger than normal, 147%, 150%, oh yeah, you've got obstructive lung disease. So it's a good diagnostic test. And that's where it comes from. So those are all volumes. We characterize them as restrictive and obstructive lung disease by just generally reduced volumes, reduced flows, volumes for restrictive, flow rates for obstructive lung disease. So that's how much. We make that characterization by how much. There's also a characterization of how fast the air comes out. That's called pulmonary mechanics. Pulmonary mechanics, we're measuring the volume in a unit of time. So a flow rate that we use volume per unit of time, FeV 0.5. I'm just going to put sec there. So generally, if we have a patient take a deep breath in, and then blow all their air out. If we start here and we exhale that way, we can plot time across this. 1, 2, 3, 4, 5 seconds. So quite simply, the forced exhaled volume, FeV 0.5, if we go here to a half a second, this is the volume in a half a second. So you just measure how much comes out in a half a second. So it's a volume-related measurement in a unit of time, which makes it a flow rate. Okay, and FeV 0.5 is a flow rate, but it's a volume measured in time, half a second. So what does the FeV1 mean then? And this is a particularly important one. FeV1. all the asthma measurements, they use FEV1. Forced exhaled volume in 1 second. Okay, FEV1. So it's the volume exhaled in 1 second. Armando, what's your FEV1? If you can get 6 liters out in 6 seconds maybe, what do you think the volume is that comes out in 1 second? Maybe 1 liter. Yeah, whatever. What do you think Megan's FEV1 is? Maybe 0.7 or 0.8. You know, a little bit smaller because smaller lungs compared to age, race, gender, right? So the point is though, is it's a volume in a half a second, a volume in 1 second. An FEV2 is the volume in 2 seconds. An FEV3 is the volume in 3 seconds. Now, interestingly enough, we know that the physical differences between males and females, between small and short and tall patients is going to be different. We compare them to normal, but we can generally say that the FEV1, the amount of volume that we should get out, so 1 liter in relation to the 6 that you can get out, what's one divided by 6? Is that about 18%? It's like 17%. Well, for a normal amount, I think the FEV1 should be about 84% of normal. So even though we can measure it and we know what that volume is, a normal patient on forceful exhalation, notice it doesn't take me to get a long time to get all the air out. In fact, I can get most of it out in 3 seconds. In 1 second, I can get 84% out. In 2 seconds, I can get about 93%. What does Desjardins say? Am I on target here? And the FEV3 is about 97%. So compared to normal for anybody of a particular age, height, sex, I know that in 1 second, this is on page 152. So it says on the FEV timed, the FEV1 I should be able to get about 83% out. The FEV 0.5 I should get about 60% out. So that's just a point of reference for normal, right? Flow rate for normal. Normally I should be able to get about 60% of my lung volume out in a half a second. After 1 second, I should have about 83 or 84% out. In 2 seconds, I should have about 92 or 93% out. In 3 seconds, I should have almost 100%. What does that tell you about the mechanics of the lungs and how fast you should be able to exhale that flow? It should all be out in 3 seconds. So patients that take longer than 3 seconds to get their air out, what's happening? They have obstructive lung disease, decreased flow rates. So the reason why it takes 4, 5, 6, 8, 12, 13, 15 seconds, a smoker who exhales their air out because of the mechanics of the flow rates of their airways, in 10, 11, 12, 13 seconds, they're still blowing out because the airways are collapsing and it's compressing because of muscular effort. It's compressing the airways and they still can't get the air out. Flow rates are tremendously reduced, and as a result, they can blow, blow, blow. So in a PFT lab, one thing that's, I don't want to scare you to death, but a PFT is a pretty rowdy place. A PFT lab is a pretty loud, rowdy place. And if you go by a hospital room that's doing a PFT, you'll have a practitioner and a patient, and the poor patient's 50 or 60 or 70 or 80 years old, and you're trying to distinguish between obstructive and restrictive lung disease, and the technician's saying, okay, now take a deep breath. Okay, blow, 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 and they're trying to get every possible effort out of the patient. And so the coaching and the explanation becomes extraordinarily important in how this air is going out. You're trying to get the very best effort you can, because what's the difference if a practitioner says, okay, take a deep breath in, okay, now blow, 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 blow. Okay, you kind of get that same effort. So I usually try to demonstrate, if I was in a PFT lab, I would demonstrate what I expected to come out. I'm going to blow as hard with as much effort as I possibly can. I'm going to blow into this mouthpiece so that I get all of the flow out and I can measure it. Nice thing about the PFT machines now is that it measures how fast the flow comes out. And so not only are you getting these volumes in 1 second, half second, 3 seconds, you're also getting minute data that the computers of today's PFT machines are spitting out and diversifying and dividing. So you get all these little pieces of information that stratify one breath out. So deep breath in, blow out as hard as you can. You're measuring how much volume comes out, but you're also measuring how fast it comes out. So they're stratifying that data and giving the practitioner all kinds of information. Okay. So an FEV, so a flow rate, an FEV 0.5, FEV 1, 2, and 3. Normal patients should get most, if not all, of their air out in 3 seconds. If it takes longer than 3 seconds, that's evidence that there might be an obstructive defect. They're having trouble getting it out, or it takes longer to get out, which would define obstructive airways. You know, airways that collapse, that trap air behind it, we become hyperinflated, we end up with an x-ray like that. So you could almost look for obstructive type changes in CBAE, chronic cystic fibrosis, bronchitis, asthma, bronchiectasis, and emphysema. Those are the obstructive lung diseases. Those diseases produce an obstructive effect that we would identify on a PFT. Everything else is restrictive. So FEV1 through an FEV3. There's another good ratio, and I tried to illustrate it with Armando. If he blows 1 liter out in 1 second, in 1 second, and then his total lung capacity, TLC, FEV1 to TLC, let's see, FEV1 to FVC, that's a ratio. So an FEV1 compared to what the forced vital capacity is, another name for that is the FEV1%. So if you see it on a PFT, an FEV1% is a percentage of the vital capacity blown out in 1 second. An FEV1 FVC ratio, or an FEV1%, that's a percentage. How much of the FEV1 should you be able to get out in a forced vital capacity? If an FEV1, you should have 83%, and a normal ratio then is 80 to 120, we should be able to get out at least 80% of our forced vital, our FEV1 compared to our forced vital capacity in 1 second. That one is a prescriptive parameter that points specifically to obstructive lung disease. And we can even stratify that number. If 80 to 120 is normal, 80 down to 60% is kind of iffy. But specifically, we can stratify using that parameter less than, well, depending on your resource. Lindsay Jones will say 60 to 75% is mild obstruction. 50 to 60% is moderate obstruction. 40 to 50% is severe obstruction, and less than 40% is OSCHNIKE. Oh, Nelly here. Oh, you can put your own adjective in there. Oh, shit. Not, because it's not good. So you can stratify the degree of obstruction. If it's within this range, it's normal. If it's 80 to or 60 to 75%, I think Lindsay Jones says mild obstruction. And so you're comparing the amount that comes out in 1 second compared to the lung capacity, the vital capacity. So you're comparing it to what the patient can do. not compared to what's normal, compared to what the patient can do. So we use this as data, and we get tons and tons of them. In fact, next semester there's a whole nother class that 4 weeks, 5 weeks out of next semester, you'll just do PFTs. So this becomes the first time you've seen PFTs. We've made sense of the volumes and capacities. We look at the flow rates and the volumes. We make sense of FEV1 to FEV3. We look at FEV1 percents, FEV1 to FVC ratios. Next semester, you'll have case studies where you're given all the data and you have to make a distinction. Okay, is this obstructive restrictive lung disease? And you'll make sense of it over time. So this is the first exposure in A&P to what these volumes and capacities mean and how we stratify the data to make diagnosis. Okay, we better stop there.
Stop it.
That's the time. Look at what we know now. Holy cow, 3 weeks.